In the late 18th century, Erasmus Darwin, the grandfather of Charles Darwin, was among the first who observed the curious connection between our inner ear and eye movement. He described how inner ear working of vestibular system could influence what we call the vestibulo-ocular reflex. Fast forward to early 19th century, when Jan Evangelista Purkinje, the brilliant Czech anatomist, took these observations further. He meticulously described how visual stimuli cause rhythmic eye movement, laying the foundation for what we know today as optokinetic nystagmus. Hello and welcome to this lesson, Nystagmus. So first, let's understand what is nystagmus. Nystagmus is involuntary rhythmic oscillation of the eye, and it can be due to physiological or pathological conditions. And there are several bases for the nystagmus. We can classify it based on direction of the movement. So we have horizontal nystagmus, vertical nystagmus, rotary nystagmus, or mixed type of nystagmus. The onset can be another basis for the classification. So we can have congenital or acquired nystagmus. Pattern is another way to classify nystagmus. We can have jerky with fast and slow phases, or pendular with equal phases of nystagmus. Another basis for classification is trigger, which can be gaze, head position, or other stimuli. And in this picture, in the right side, you can see the nystagmus, types of nystagmus based on direction of the movement. So here we have horizontal nystagmus, where the eyes are moving like this. We have a vertical nystagmus, when the eyes are moving vertically. And the last one is torsional or rotary nystagmus, where the eyes are rotating around an axis. So before we dig into the nystagmus and pathology of nystagmus, we have to understand the physiology of eye movement. And we have three main components that are crucial for you to understand the nystagmus. First of all, we have vestibulo-ocular reflex, and this is extremely crucial, and I'm going to explain this in the next slide. But basically, vestibulo-ocular reflex maintains the stable gaze during the head movement. We have input from semicircular canal feeding into the brainstem nuclei, and this generates the compensatory of eye movement. Another component of physiology of the eye movement is ocular motor control, and this is the coordination between cranial nerves 3, 4, and 6, which ensures the smooth gaze holding. Another component of physiology of the eye movement is cerebral integration, and cerebellum actually refines the signals that are coming from vestibular system and brainstem, and actually they are refined to have precise movement. So a normal pathway for eye movement is when we have a stimulus, which can be head movement or visual input. After that, we have involvement of vestibular apparatus. After that, we have involvement of brainstem nuclei, cranial nerves, extraocular muscles, and as the result, we have a coordinated eye movement. When we have nystagmus, there's a break point in this pathway, which results in involuntary oscillation of the eye. So now let's understand vestibulo-ocular reflex pathway. And knowing the VOR, vestibulo-ocular reflex pathway, is extremely important for you to understand the nystagmus. So first of all, what is VOR? What is vestibulo-ocular reflex? This is a critical reflex that stabilizes vision by adjusting the eye movement in response to the head motion. When your head moves, the VOR ensures that your gaze remains fixed on an object by producing compensatory eye movement in the opposite direction of the head movement. It has several steps. The first step, which is coded here with the 1, is the stimulus, which is the head movement. Head movement is detected by semicircular canals of the vestibular apparatus in the inner ear. The semicircular canals are oriented in 3 planes, allowing the detection of the rotational head movement. The second step is vestibular nerve activation, number 2 in this picture. So this is when we have sensory input. The movement of the head causes endolymph in the semicircular canals to move. This is going to deflect the hair cells in the ampulla of the canal, leading to depolarization or hyperpolarization depending on the movement and direction of the movement. So after that, we have hair cells that are sending signals to the vestibular nerve, which is cranial nerve 8. The third step is when we have vestibular nucleus. So this is where we have processing. The vestibular nerve transmits signals to the vestibular nucleus in the brainstem, which is located in the pons and medulla, and depending on the direction of the head movement, we are going to have either excitatory or inhibitory signals that are distributed to control the compensatory eye movement. خب از قسمت 4 شروع میکنیم ضرب. 1 2 3. So the fourth step is motor output, and this is where we have activation of extraocular muscles. Signals are going to be sent to the oculomotor cranial nerve 3, trochlear, which is cranial nerve 4, and abducent, which is cranial nerve 6 nucleuses. So these cranial nerves are controlling the extraocular muscles. For example, cranial nerve 6 is controlling lateral rectus muscles. Cranial nerve 3 is controlling medial rectus muscles. The superior and inferior oblique muscles are being controlled by cranial nerve 4 and 3, and superior and inferior rectus muscles are being controlled by cranial nerve 3. Now, let's have an example to see how this works. For example, imagine that your head is going to turn left. So the left horizontal semicircular canals activate the right lateral rectus, which is cranial nerve 6, and left medial rectus, which is cranial nerve 3, and activation of these two nerves are going to pull the eyes to the right to stabilize the gaze. The next step is eye movement, which is compensatory gaze. The eye movement is in opposite direction of the head movement to maintain the fixation of the visual target. And this is how vestibulo-ocular reflex pathway works. So now let's talk about the first class of diseases that can cause nystagmus, and we are classifying this as a peripheral vestibular nystagmus, meaning that these are peripheral causes by the vestibular system causing nystagmus. So in this case, we have damage to the vestibular apparatus or vestibular nerve, which creates an imbalance in vestibulo-ocular reflex input, leading to the slow compensatory eye movement in one direction and fast corrective action in opposite direction. We have several diseases that can cause this type of nystagmus. For example, the first one is benign paroxysmal positional vertigo, when we have dislodgement of the otoliths in the semicircular canal causing positional nystagmus. Another disease that can cause peripheral vestibular nystagmus is vestibular neuritis, viral inflammation after a viral disease, for example, common cold, which disrupts the vestibular input unilaterally and produces the horizontal nystagmus. Another disease that belongs to the peripheral vestibular nystagmus group is Meniere disease, when we have abnormal endoleaf dynamics, and this creates an intermittent nystagmus with the vertigo. So the key feature when you have peripheral vestibular nystagmus is horizontal or rotary nystagmus. It is going to be associated with the vertigo, nausea, and ataxia because the vestibular system is involved. And also note that in case of peripheral vestibular nystagmus, we have suppression by the visual fixation. So there are several mistakes that you can make in the exam, and you have to be very careful for them. For example, misdiagnosing the peripheral nystagmus as a central based on history alone, or even overlooking the positional triggers in the BPPP scenario. So we talked about the peripheral causes of nystagmus. Now let's talk about the central causes of nystagmus. And this is when we have damage to the cerebellum, brainstem, or vestibular nucleus. And this is going to disrupt the integration between visual pathway and vestibular pathway. There are several examples that we can bring for the central causes of nystagmus. For example, we can have cerebellar lesions, damage to the cerebellum by the stroke or even multiple sclerosis, and this is going to impair the gaze pathway and it causes the gaze-evoked or rebound nystagmus. Another cause can be wernicke encephalopathy. This is due to thiamine deficiency, especially in alcoholics, and this is going to damage the brainstem and cerebellum. And note that in this case, we are going to have a vertical nystagmus. Another causes of central nystagmus, which can be caused during the childhood, is Chiari malformation. As you know, Chiari malformation is defined as a herniation of the cerebral tonsils, which disrupts the vestibular cerebellar pathway. So here we have several key features: vertical or multidirectional nystagmus. One of the most important notes for exam is that the nystagmus is not going to be suppressed by the visual fixation, and it is going to be accompanied by ataxia, dysmetria, or cranial nerve signs based on the etiology that is causing the nystagmus. There are several points that you have to know for your exam. First of all, you have to recognize the vertical nystagmus, which is the hallmark of the central nystagmus. And another point and another source of mistake that you can make in the exam is that there are several other neurological symptoms that would be associated with central nystagmus, and sometimes a student miss those symptoms and miss central nystagmus. Another type of nystagmus, another causes of nystagmus is when we have drug or toxin induced nystagmus, and this is direct toxicity to the brainstem or cerebellar pathway from the drugs like anticonvulsants, sedative, or alcohol. Probably the most famous example is phenytoin toxicity or alcohol intoxication, and here we have several other features. For example, horizontal or gaze-evoked nystagmus is a very important feature that you have to know for your exam. The nystagmus is going to be bilateral with no association with vertigo. And things that you might miss in the exam is the medication history in the scenario. So always, if you are suspecting the drug or toxin-induced nystagmus, look for the medication history in the clinical scenario. So the second type of physiological nystagmus is optokinetic nystagmus, and this is a physiological nystagmus, and the purpose is to stabilize the images during the sustained visual motion. So we have some characteristics to this type of nystagmus. It is a jerky nystagmus. It has slow phases and it has fast phases. And the pathway that is going to be involved in this kind of nystagmus is first of all visual input. So we have retina and occipital lobe, which is the visual cortex. We have involvement of the brain stem. So the vestibular nucleus is going to be involved in this type of nystagmus, and also extraocular muscles, which are activated by cranial nerve 3, 4, and 6. So this kind of nystagmus actually used as a bedside test to assess the visual and brain stem function, and the absence of optokinetic nystagmus might be an indication of a lesion in the parietal occipital pathway or even in the brain stem. Another type of nystagmus is vestibular nystagmus, and this one can be either physiological or pathological, and it is caused by a stimulation or dysfunction of the vestibular system. Causes can be the imbalance between the vestibular input from the left and right inner ear, semicircular canals, and the characteristic is that, first of all, this nystagmus is going to be horizontal or rotary. It is a jerky nystagmus. It has fast phases and it also has slow phases. For example, here, if we have physiological vestibular nystagmus, it can be rotation-induced nystagmus. For example, when the patient is spinning in a chair. In the pathological causes, we can have vestibular neuritis or Meniere disease. And the pathways that are involved in this type of nystagmus is, first of all, vestibular input. So the head motion stimulates the semicircular canals, leading to activation of vestibular nerve, cranial nerve 8. After that, we have brainstem integration. So vestibular nucleus in the brainstem processes asymmetry in signals and relays to the cranial nerve 3, 4, and 6. And after that, we have eye movement. Eye moves in the opposite direction as we talked before of the head movement. So we have a slow phases here, but they are going to be resetted rapidly by the fast phase. So it has some clinical significance. For example, pathological vestibular nystagmus is often associated with the vertigo and nausea, and the direction of the nystagmus helps to localize the lesion. So we can have central with vertical nystagmus or peripheral with rotary nystagmus. So here is a comparison between physiological and pathological nystagmus. So in the normal physiological nystagmus, we have triggers like head movement or visual stimulus. The direction is going to be controlled by the stimulus, and it is going to be suppressed by the visual fixation, which suppresses the vestibulo-ocular reflex. And we do not have associated symptoms here, and usually the vision is stable. In opposite to that, we have pathological nystagmus. So here the trigger is going to be lesion, inflammation, or systemic imbalance. It is often unidirectional when we have peripheral nystagmus, or multidirectional when we have central nystagmus. And central nystagmus usually causes often resistance to the suppression. So with the visual suppression, we are not going to have suppression of the nystagmus. And usually there are some associated symptoms like vertigo, diplopia, or ataxia with the nystagmus. So here is an interesting case that you might encounter on the topic of nystagmus in your board examination. If you want to solve it, please stop the video, try to solve the problem, and leave the answers in the comment section. Thank you for watching. Goodbye.